the UK, 3 million people live with kidney disease. There is no cure. And those of South Asian descent, like me, are 5 times more likely to get kidney disease. I was 18 when I was diagnosed with an aggressive form of lupus. This led to my kidney failure. I needed dialysis 3 times a week to stay alive. I was put on the transplant waiting list.
Organ donation and Islamic perspectives, and specifically looking at opt-out, the impending law change in Scotland. I am your chair this evening. My name is Neerja Jain. I'm Health Equalities Programme Manager with Kidney Research UK, and by background I'm a kidney specialist nurse. So as you'll hear from Bushra, my colleague, in just a moment, normally we would love to be out and about in the communities, raising awareness of these life-changing issues face to face. But obviously, because of the pandemic, we're having to do things rather differently. So this is our first webinar, I hope of many. Please bear with us, just in case we have any minor hiccups. Hopefully we won't. Now, before I carry on, I just want to alert you all to, there should be a questionnaire in the chat bar. So you'll probably just have to hover around and look for the chat bar, and there is a questionnaire in there, which we would really like you to complete, please. It's to help us gauge how well these events will, how effective these events are. So we really like to know a little bit about yourself, your thoughts and views about organ donation. And then there's a section afterwards, after this webinar, if you could complete that as well, so that we can gauge kind of the effectiveness of this webinar today. Really appreciate your help in doing that. You're going to have a great array of talks ahead of you this evening, and really it's very apt because it is Organ Donation Week in the UK, and you'll have your own opportunity to ask questions right at the very end. I'd like to first of all thank our hosts, Al Mazan. Thank you so much, Shama and colleagues, for hosting this webinar, and to our funders, Scottish Government. Just to let you know as well that this webinar will be recorded, so that we can have an even greater reach and more people can take advantage of all the wonderful information you're going to hear today. And as a reminder, please do check out that questionnaire before, well, as soon as
it's the most successful one in the UK. We've also won many awards, some such as the Impact Award at the SEMPO Awards and the Scottish Asian Business Awards as well. So this is just a couple of pictures of the peer educator volunteers that have been working within the community and some of the awards that we have won in the past couple of years. So kidney disease ends here. This is our motto. And for further information, please do come onto our website. And if you need any other information, please, you can contact me as well. Thanks very much.
Lovely, thank you very much, Bushra. Just to say that as well, that we will be taking questions right at the end, so you will have an opportunity then. Just another plug for the questionnaire. If you haven't gone onto the chat bar to fill it out, please do. We want to get as many of your thoughts before we finish the webinar, in fact, as early on as possible. Right, okay, so next speaker is Dr. Saeed Ahmed. And he is a consultant kidney specialist and general medicine physician. He's the BAME Network Lead and British Islamic Medical Association Organ Donation Lead. Saeed holds several other roles, including as Newcastle Muslim Funeral Association Secretary. He trained in Newcastle and London and has a particular interest in interventional nephrology, leadership, mentorship, teaching and training, as well as health promotion in BAME communities. Thank you, Saeed.
Thank you, everyone. Can you hear me okay, everyone? Yeah, so Assalamu alaikum, hello, Sat Sri Akal, and Namaste. So I think I've got everyone, hopefully. If I missed anyone out, you please need to teach me a few more languages. Right, so I'm going to share my slides. So let me do this first. Share screen. Okay, And in a minute, you'll see my slides. Okay, can you see my first slide, everyone? Okay,
Yes.
it should say BAME and organ donation. Okay, thank you very much for the kind invite by Kidney Research UK and the good people of Scotland. This is somebody from the south, not too far from Newcastle, and today I'm going to speak to you about BAME and organ donation. A little bit of repetition, but we don't really mind that at this stage. So BIMA, which has already been introduced, is British Islamic Medical Association. We are healthcare physicians, from pharmacists to allied healthcares to doctors, voluntary service. And just a little plug, what we do, well, we're here to serve you as the community, you as our sort of neighbours, brothers and sisters. Unite, inspire and serve. We wish to give back to where we came from, i.e. from the community. So that's our inspiration, and we're about 5 years old. We're not as old as Kidney Research UK. Here are our programs. We do a little bit on acid attack in females, health and mental health in Hajj, women excelling in healthcare, cancer screening, Ramadan, and lifesavers. But today I'm going to talk about organ donation as the prime subject. So let's set the scene. And Bushra set it very nicely already, talking about the ethnic minorities. This is the latest data set, and it's a very busy slide. I don't want you to concentrate too much, but lots of figures will be thrown at you. The best data we have is from the OCNS, so the National Census from 2011. So we're waiting for the 2020 data to come through. And it tells you that within a community, there's another community. So we call ourselves a community of people living in the UK, but there's many subdivisions and there are many differences. And we know that in healthcare, health inequality, and maybe I even plug Neera Jain's work in Leicester when she looked at health inequalities with Professor Feely many years ago. We know that they exist, but why do they still exist now? Well, because the demographics are different. And here are some of those demographics. And to point out that the diversity, a lot of the, in this case, from Muslim Council of Britain, the MCB, are producing a report saying some of the boroughs in the UK with the highest deprivation have the highest concentration of Muslims. So it is not just ethnicity, there's something about social demographics, there's something, all of it listed together in multi-generation families. So there's a lot in here to unpick to find out what's going on. But this is one infographic just to focus your mind on where we're talking about today. Okay, so moving on really quickly into the issue of BAME and transplantation. Now you hear different figures. Roughly, the BAME community, Black, Asian, minority, ethnic, is 11% of the UK population as of the last census. Asians represent 5.1% of the UK population, where 2.5% of the population are other Black and ethnic minorities. So we're around those figures, around 5 to 10%. In contrast, and this is the capacity and demand will come again and again, in the same financial year, 2017-2018, 35% of the total number of patients waiting on the kidney transplant waiting list are BAME. So another way to think about it is 3 times more people are waiting on the waiting list than are in the population itself. And this is far exceeding the demand, more so than the white Caucasian. And in the UK, people from the Black South Asian background are more likely to suffer from a number of diseases: obesity, type 2 diabetes, high blood pressure, something called cardiovascular disease, which are conditions affecting the heart and blood vessels. And all of these diseases are more aggressive and also develop quicker and reach complications more quicker in Asian and Black Asian groups as well. So there is a number of issues here to unpick from having this increased propensity, increased risk that we all know about. Allied to the high demand of kidney transplantation for BAME, 28% of kidney transplants were in BAME recipients. So this is a very important point which will come out later. More people, so let's get it really crucial here. I'm going to be very careful with my words, but I don't want to upset anybody. More Black, Asian, minority, ethnic receive white kidneys than give kidneys into the donor pool. You are more likely to receive, as an Asian, minority, ethnic, even if you believe or not believe in donation, you're a Muslim or not a Muslim, but if you're BAME, you're more likely to receive a white kidney than a BAME kidney. These 2 points are important, because when we go further into I'm happy to receive a kidney when I need it, because we're all a little bit selfish in our healthcare, but not to give. I'm not happy to go and give, but I'm happy to receive. And this is the facts showing that we do receive a lot from our white Caucasian members of society. And then obviously, due to the discapacity and demand, BAME people wait a bit longer. Not as long as they used to, they wait up 2.5 years longer than the white Caucasian. So not only do you get to end stage, maybe in this case, renal failure, and end up on things like dialysis, but you wait a little bit longer on the donor list, waiting for that kidney to turn up, because of the capacity to donate to you is less. And the disadvantages made even more apparent is the best kidneys for a BAME individual should come from the BAME community, i.e. because of A, blood group matching, and 2, tissue type matching. Common things are common. You're more likely to have common tissue types within the community you live in, especially in an extended family, and more likely to have a common blood group, because we know Asians' blood groups are slightly different to white Caucasians, and therefore these 2 factors make it more likely you'll find a donor within your community if they're healthy to donate, whichever way they donate, and we'll come on to that. So blood and tissue types differ across ethnic groups, and the fact that only 7% of deceased donors in the UK are from minority ethnic, while 35% are waiting, you know there's going to be a big demand and capacity issue on the transplant waiting list. So it is important to recognize that we are, as a BAME community, using a lot of resource of the NHS, a lot of resource, and we are very proud and we feel privileged that we live in a part of the world where this is available to us, because all of us from extended families will know from countries back home this is not the case. So let me now look at that capacity demand in a slightly different way, which is the types of donations, and the words we're going to use are DCD and DBD, and I'll explain them a little bit later. But basically, you have to pass away and currently have an organ donation card, or have deemed to be presumed consent, which we'll talk about by the Scottish Government. But let's look at the hard facts. How many deaths are we really talking about in the UK that can somebody, a loved one, deceased in the right way and donate into the donor pool? So this is figures from 2018-19, just to concentrate your minds. 600,000 people died in 2018-19. This year might be slightly different due to COVID, but forget COVID. This is 2018-19. Of those, you have to die in hospital. So it was 290,000 deaths in hospital. You cannot donate if you die outside the hospital. Out of those 290, look at the numbers. We're almost down to 1% here. 6,991 potential organ donors. So 600,000 died. So we're here, only 1%. So it is not like that everybody donates, only 1%. So when the circulation ceases, there is only about 20 minutes, and that's why you have to be in hospital. That's for this to happen. To be in a position to donate, the organ must die on a mechanical ventilator in a hospital setting. So that straight away rules out all community deaths. This is only hospital deaths that we're talking about. And this is 1% of all deaths. So we're talking about a small number here. To be in position to donate an organ, you must die on a mechanical ventilator in an intensive care or emergency department with no absolute medical condition preventing donation. So we will look at that at that time. The organ donor procurement teams will look at that. So this is the situation. We're now down to 5,000 deaths. And that number decreases further because not all of those people are potentially going to go on to donate. They may be physically stable and have a good health prior to their sudden death. Got to be sudden death like that. But then we have to ask the family. And then there is a refusal rate that we talk about. And then we're down to 2,181 deaths. So see how the number of deaths are coming down. And that has to occur within 12 to 24 hours of somebody deceasing. So actually per year, we've only got 1,600 deaths that are potential donors for the organ donor register for those people. So that is the amount of capacity we have in the system. And 62% of deceased organ donor deaths are usually of older people. And the primary cause of these deaths, because they're otherwise fit, is usually something is happening wrong in their brain and they've had a bleed in the brain. So it's not a car crash, it's not cancer, it's not horrific other problems. They've got to die in a certain way. Hence, we're only looking at 1,600 deaths. This is less than 1% of all the deaths in the country that are potential donors. Now, let's compare that, what happens in the BAME community. We also already said BAME community is 10 to 12%, whatever data you look at. These are the same figures. So on this side, I pointed out, on this side, you can see a 62% consent rate of patients passing away in the right way. Whilst if you had a BAME community, you can see here, in the BAME community, with much smaller number of deaths. We're talking about 121 deaths per year that are suitable for donation from the Black, Asian, minority ethnic group. And there is a slightly lower consent rate. What that means is the family refusal rate. So if certain things we can do right now is, if we feel ourselves to be on the organ donor register, whichever the law is, it doesn't really matter at that stage, but if you've chosen physically to do that, you must inform your family. Because at the time you've deceased, or on the ventilator, you won't be able to change your family's mind. And if you haven't informed your family, then in the BAME community, 42% of the time, you get the answer that you wished for, which is, I wish to donate. But almost 60% of the time, it doesn't occur. So straight away, changing that mindset would increase this small number, which will help the people on the donor waiting list. So can you see here, this is the capacity we have per year. 1,600 deaths in total, 121 in the BAME community. And again, this is looking at live donors. This is slightly different, and I don't want to concentrate on that, but that is sort of a similar number of low, 149 from the BAME community and 1,000 from the UK white Caucasian community. So let's define a little bit, and we'll reiterate that. What I'm talking about is the type of death, the death that occurred in hospital. I'm not going to talk about living donation. I talked about donation from deceasing, and I'm talking really about organ donation, not tissue donation. That's a separate talk. Organ donation, and there's two types of death that occur in hospital, and this is now will come important when we discuss the Islamic rulings on this. So the two deaths are organ donation after brainstem death and organ donation after circulatory death. Now, you would think, in the way of modern medicine, we would know when somebody dies. Actually, it was easier many years ago, 20, 30 years ago, or even 50 years ago, to categorically say that somebody is dead. With modern medicine, it becomes more difficult, because saying somebody's got circulatory death is easier than saying somebody's got brain death. So brain death is a recognized feature which occurs in intensive care with two senior physicians following a criteria, but in this case, the brain is dying, but the heart might be beating, and the lungs might be working, and the blood might be flowing. That is one of the big things to understand. Organ donation after circulatory death is what a lot of people will understand, is when the heart would stop, the blood vessels will not have blood pumping through them, and the breathing will stop. So these two definitions are important, because more and more people will be going through this kind of death on intensive care. So donation after brain death of the two groups is the majority. 60% of all those 1,600 donors, I said, 60%. Patients mechanically ventilated, patients where death has been confirmed using criteria. So the word neurological means that the brain criteria are used by two senior physicians, usually anesthetists who are trained in this field. And the criteria are followed from the diagnosis of death in the United Kingdom is coded by the certain colleges that are showing the strict way to follow this through. And they have to be in agreement. And it's not a matter of clinical, but also some testing is done and some brainwave testing is done. So that is how that is recognized in the intensive care unit. So the other one, donation after circulatory death, occurs in 40% of the donation. So the mechanically ventilated patient with a devastating injury, usually a brain injury, where the agreed decision is to withdraw the life-sustaining treatment. So withdrawal of the life-sustaining treatment, in this case, could be drugs, mechanical ventilation, support that we stop. And following withdrawal of life-sustaining treatment, the circulation stops within 3 hours. Death will be confirmed using circulatory criteria, and donation can occur. So such as the heart stops, the blood vessels are not full of pumped blood anymore, the breathing stops. So these are the two criteria we use to recognize death and then make sure that a patient is appropriate to go on to donate. All of this is in the hospital, and these are those 1,600 deaths that I talked about. So it's a difficult concept to understand, and then hopefully we'll do, have some Q&A about it. So where are we right now? To the transplant waiting list for the last 8 consecutive years. So I've got time along the bottom of this axis, and I've just got a number of patients being transplanted and on the transplant waiting list itself. So not transplant, on the waiting list. And you can see the waiting list has come down, but we can also see in this group that transplant from deceased and living donors together, and transplants from deceased donors, which I've just talked about here. So these are the ones with brain stem death or circulatory death, and transplant from living donors. So there is improvement. The overall list is coming down, which is good to know. So we're down to about 6,000 people now are waiting for an organ from the transplant waiting list. Let's break this down into the BAME community. So here we've got time along the bottom again, and median waiting times. So I talked a little bit about that, you wait a bit longer. So if you're a Black patient or an Asian patient, this is your wait times. Your wait times over the many years from 2009 to 2016, on this case, the kidney transplant waiting list has come down from 1,400 days down to about 1,000 days. But in comparison to the white Caucasian, it is still longer. So it's longer by 32 months in the Black patient, 27 in the Asian, and it's 21 months. And you might not think, oh, this difference, 6 months. 6 months is not a big deal. Well, 6 months is a big deal, because that could be the 6 months that you deteriorate in health and then didn't become stable to go on to dialysis and then have a transplant. So yeah, every month makes a difference for our poor patients on the dialysis program. That why do they wait a little bit longer? Well, we've had some idea what that is due to. However, we do want transplants, and we want transplants across all the organs. So if you get a kidney transplant, 5 years, that kidney's survival is at 5 years is 87%. That's much better than you would get on dialysis, and therefore it's worth having. And similar with all the other organs, 5-year survival, so how long you survive with the organ, are all very good. So in liver, lung as well, and in heart. So we know that the quality of life of our patients are improved when we give these particular organs compared to where they are. Now, we know that if you don't have a transplant, you can go on the kidney machine, but there's not many liver machines or lung machines or heart machines available. So unfortunately, these individuals in these other organs will not survive, and they will succumb to death if they don't have an organ in a timely manner if they're deemed suitable for one. Okay. So it's a very good outcome. So with that in mind, there was a change in the UK law, and you'll find out about your Scottish law very soon. The name for this law is Max and Kira's law, and this was based on this young man's story who had a heart transplant. So here are, just to say, this is Max and Kira. This is the young man here who's had a heart transplant from these two. This is a daughter, and there's a brother and sister, and their brother passed away, but the heart was donated to this young man. And he then received the heart, and is ongoing. So organ donation law has come about by change in May 2020 in the Britain, and it will be coming along in Scotland as well, as we'll hear later on. So it's important that we have awareness of this, because we do not want to be going into the change in law without awareness. And the reason we change the law is to improve that capacity and demand that I talked about. However, my job in BEMA is to make sure that people out there are fully aware of what is going on. It isn't not fair that you receive your misinformation through things such as WhatsApp or social media or Twitter, but not through the proper channels. And some of the concepts in BEMA that we fight against is these kind of fake news that comes in through usually WhatsApp. A reminder to all residents in the UK are now automatically on the organ donor register. If you don't opt out, your organs and tissues are now the property of the UK after death. So that was prevalent in social media prior to the law change in the UK. And this is what we put out, and then we put out against that, obviously corrections and debunking and demystifying. And it's fine, but the horse is usually bolted. So what we want to do is to increase the awareness prior to a change in law. And we've had practice. Wales have changed, the British have changed, now the Scottish are going to change. And therefore we've had practice. We know what is going to happen. So we really must be on the front foot to negate or mitigate some of these fake news. Final call out really is that a lot of the information I've talked about is available on the British Islamic Medical Association website and also NHSBT. Regarding particular religions, Faith, Beliefs and Declarations introduced in December 2018, there's a lot of, out there on the NHSBT website where you can go to specific groups and learn about different faiths and different in Muslim group, the fatwas that have been out there. The issue really with the fatwas is that there are so many, and many of them all agree, but it is not usually that. It is the awareness, and the awareness is at two levels, what we found out so far. One is public, but the next one is your faith leaders' awareness. Really improving your faith leaders' awareness, because most of us who are in the public, so if I was somebody in the public and had a question, I would go to my faith leader. And if the faith leader couldn't answer it, that's their problem, because they're not aware. And so that becomes my problem as a physician, because I need to increase their awareness. So I hope putting that all together gives you a flavour of what we've been trying to do in BIMA, and also working with Kidney Research UK, and hopefully we'll have some Q&A later on. So thank you very much for your attention.
Thank you, Dr. Saeed Ahmed, for that. I appreciate that normally you speak about this subject and have a lot longer, so I do appreciate your time on that. So, okay, I would like to now introduce our next speaker. It is Fern Morris. She's a policy manager working on implementation of the opt-out organ and tissue donation system for Scotland. She's been at the Scottish Government for over 10 years, with experience in ministerial private office, alcohol policy, and most recently working on the development of the legislation for the opt-out system. Thank you, Fern.
Hi everyone, and thank you for that introduction, and thanks for inviting me back here again. I was speaking at a similar event I think it was back in January, at that point pre-COVID, and we were going to be moving to the opt-out system in autumn of this year. Obviously things have changed a bit, so we're now looking at revised timescales, because obviously we had to refocus our attentions to deal with the pandemic. So we're now looking, as we mentioned, at March 2021 for the new opt-out system. So I'm just going to tell you a bit about the new system and what it means for everybody. I'll just skip ahead. Great. So the first thing to say is that in developing the new law, we really wanted to make sure that we retained this element of the gift of donation. For people waiting for a transplant, it's a massive life-changing gift for people, and a really precious gift. And I know we're going to hear a bit more about that experience a bit later on. But it's so important that we reflect in the law that it is such a huge gift, not only for the recipients, but also for the donor families. It's something that comes at a time of such great tragedy, when they're coming to terms with the loss of a loved one. And it's out of that great tragedy can come something positive. And so we wanted to make sure that we retained that element of the gift. So throughout the legislation, there are safeguards that aim to retain that idea, and to make sure that people's the potential donors' views are first and foremost in the donation process, so that we retain this idea that it's a gift, it's something that is given willingly. And we've tried to make sure that we reflect as much as possible the donation process as it is at the moment in the new law, and the discussions that take place with families at that really difficult time when at the end of the life. And I know that Dr. Sundran is going to speak a bit more about those discussions that take place with families at the end of life in the intensive care unit, about what their loved ones' views were, because that's central to this law change, is the potential donors' views, and making sure that we can make sure that those views are respected at the end of their life about whether they become a donor or not. So just a bit about why we're changing the law, and we've kind of hit on some of these points already, but so I'll just quickly go through this. So we know that because of all the work that's gone on over the past decade and more, awareness raising campaigns, TV campaigns you'll see on the TV, and work of the peer educators, and awareness raising events like this that encourage people to think about donation and to make a decision, we know that the number of people on the register has increased over time. So at the moment we're on about 50% of the Scottish population has opted in to become a donor. But we know that a lot more people than that actually support donation and would be willing to become a donor. We know that around 90% of people say they would be willing to become a donor, but for one reason or another, people don't get around to actually opting into donation. So there's a gap between people's intention to donate and the reality of actually going to make a decision to donate. And moving to an opt-out system is one way to better reflect the support that there is for donation in Scotland. And just another slide on why we're changing the law. Dr. Ahmed's already touched on this. There's quite a limited pool of people that can become donors. As Dr. Ahmed said, about 1% of people die in the right circumstances, so dying in an intensive care unit. And that's the only way that people can become organ donors. So there's quite a limit, and there's been lots of work over the past decade and more to try and make sure that all the opportunities that arise are maximised, so that we can increase the numbers of donors and increase the numbers of those life-saving transplants. But there is a natural limit, and on the other side of that, we've got about 500 people at any one time waiting on a life-saving transplant in Scotland. So again, it's important that we do everything that we can do to improve the lives of those on the transplant waiting list and increase the chances of them getting a transplant. So just a bit about the new law, just very briefly. The first thing to say is about choice. So people still have a choice under the new law. People will still be able to opt in as they can now, and you can do that on the organ donor register, and they'll still be able to opt out as they can do now on the organ donor register. The thing that will change is that from March 2021, if you die in circumstances where you could become a donor and you haven't opted in or opted out, then the assumption will be that you're willing to become a donor. And it's important to say that that's only about donation for transplantation. It's not for any other kinds of donation for research or government ownership of organs. It's just about transplantation, about saving another person's life through organ transplantation. And it's important to say it's only as well for parts of the body that are commonly transplanted. So that's things like, has been mentioned, the kidneys and the liver and the heart and organs like that. So that's the basic principle of the new law. You still have a choice, but if you don't make a decision on whether you want to opt in or opt out, then the law will assume you want to become a donor. But it's important that alongside that, we do have safeguards. As I've said, we want to make sure that donation remains a gift, and it remains about the potential donor's views and whether or not they become a donor. So built into the system, there are checks. So by law, it will be required that the family and other people that are near to that person, that are in that person's life, are asked about what their views were. So would they have been willing to become a donor or not? And if the answer is no, they weren't, they've told me they didn't want to become a donor, then that will be respected. And it's all about making sure that it's the potential donor's views that are brought forward and that ultimately decide whether or not donation can go ahead. And this can take in their views in all kinds of circumstances. Dr. Ahmed talked about the different types of death, DCD and DBD, so it can take into account whether a person might have been willing in some circumstances and not other circumstances, to make sure that donation only proceeds in the circumstances that that person would have been willing for it to proceed in. Next, there are protected groups that the new law won't apply to. So this is to reflect the fact that some people might not be aware or might not understand the new law. So it will only apply to adults in Scotland. So in Scotland, that's from age 16. So if anybody under age 16, the law won't apply to them, the new law won't apply to them. It also only applies to people who've been resident in Scotland for 12 months. And it also won't apply to people who wouldn't have been able to understand the change in law and what it would mean for them, and the fact that they needed to opt out if they didn't want to donate. So people with dementia or conditions like that, which would mean that they wouldn't be able to understand what the change in law meant. And so for those groups, if somebody in one of those groups dies in circumstances where they could donate and they haven't already recorded a decision whether or not they want to donate, then it'll be a decision for their family about whether they want to donate their loved one's organs. And finally, is about the tests. So these are tests that are currently carried out as part of the donation process, things like blood tests and urine tests, which take place to ensure the safety of transplanted organs and to ensure there's a good match for the recipient. And these take place at the moment. They're a routine part of the donation process, but the law makes it clear that these are part of the donation process. So when you agree to donation, you're agreeing to these tests taking place. And just as with the checks about what your views are about donation, the law requires that your family is asked about what your views would be about these tests, again, to make sure that these don't happen if you wouldn't be happy for them to happen. So again, it's coming back to the donors' views about what they would want to happen to themselves and putting that first and foremost in the whole process to make sure nothing happens to them that they wouldn't be happy to happen. And finally, I've gone through this very quickly, but I'm happy to take some questions at the end of the evening. This is my final slide. So it's just about, before we can change the law, we have to make sure that people know about the new law. So we started our awareness raising campaign last summer, letting people know that the law would be changing. We've changed the date, obviously, but the principle stays the same, that the law will be changing from March 2021. And awareness raising started on that and will ramp up as well as we get closer to the date. And what our awareness raising campaign is really encouraging people to do is to let them know about the law change, let them know about what their choices are, so they can still opt in, they can still opt out, but what it means if they don't do those things, and also to encourage them to register their decision, and most importantly, to let their family know what their decision is. We know that if people want to donate and they've registered, it's more likely to go ahead when the family knows about what that decision is and they support that decision. As I've said, the law is about the potential donors' views, but we know families are so important in the process and they will continue to be important under the new system. So we really want people to have those discussions with their family, so their family knows what they want, they know what their families want, so that if the worst happens, they know what they would have wanted and can support that donation taking place or not taking place, as the case may be. It's a very personal decision, and we don't want to tell people, people need to make their own decisions about whether they want to become a donor or not, but it's about having that conversation with your family so everybody knows what you would want if the worst came to it. So hopefully you might have seen some of our campaign materials already about the law change, and you'll probably see more of them as we get closer to March 2021, encouraging people to have those conversations. Thank you.
Lovely. Thank you very much, Fan, for that. As I said, we will take questions at the end. Can I just give another plug for the questionnaire if you haven't completed it? So next I will be introducing Azra Ahmed. She is a kidney transplant recipient of nearly 4 years. Azra is a mother of 2 and a housewife, and she tells me she loves cooking and baking. So next time we get together, I hope we can sample some of her culinary delights. In the meantime, I'm delighted and grateful that she's helped us with so much outreach work in the past, and that she's here today. You will just be seeing Azra. She hasn't got any slides, but please wait and listen to her story. Thank you.
Hi everyone, thank you John, thank you Bushra for having me on. I'm Azra, I'm 48 years old. I should say late 40s, but I'm 48. I'm married for 28 years, I've got 2 children. Everything was going pretty normal, pretty usual, until went for routine blood tests, got a call from the doctor the next day saying to come back in. Creatinine was extremely high, so the GP said that we'll call you back in a week. She goes, just drink water or whatever, come back in a week. Went back in a week, and the GP was like, "What have you done?" And I'm like, "Well, I just drank water." And she goes, "Well, everything's gone normal, but I'm going to refer you to the renal clinic." So we did. Function was at 30% at that point. So they were like, they wanted to put me on dialysis straight away, but I didn't have any symptoms. So there was nothing, there was absolutely nothing there. So they said, just keep an eye on me, keep me at the clinic, blah, blah, blah. So I had a miscarriage in between that brought my kidney function down to 15%, still going well. Then in 2016, started my dialysis. So I became one of the stats for dialysis / organ transplant. And the way it was, I ended up with a central line, which is basically what they call the CVC catheter, which is inserted on your neck or upper chest or in the groin. Mine was the upper chest. Honestly speaking, I loved it. You had to have your fistula on your arm. It seemed very sore where the veins are used all the time, but touch wood, my central line was fine. They kept it like that. Had a fistula, but it died. So continued with that for a year. When I was in hospital, hubby had opted himself to become an organ donor for me. So there was no discussion. I was just told that he was going to need me. I suppose being selfish and whatever, I didn't really want him to donate. I convinced my cousin that, can you please get tested? But husband was like, no, I'm going to get tested. So tissue typing, everything started in March. I was going to dialysis 3 times a week. It was smooth, but it has its ups and its downs. Quite a upheaval of health and life, going out, diet restrictions, fluid restrictions. You can just imagine if it's hot and you just think, okay, I'm just going to have some water, but then it's not a glass, it's only like a little sip, a couple of sips you can have. So you have to savor them. And but it was friends and family, everyone around was really good, very understanding, very caring. So that continued. Then just going on, I had initially, when I was diagnosed with my renal disease, because when I was told I was in stage 3, so hence the doctors wanted me to start dialysis straight away. And then, so I had opted to do it at home, peritoneal. When it started in hospital and I saw how much care was taken, hygiene, if you're not feeling well, there's someone there, the machine beeps, because you can crash, you can feel sweaty, you get cramps, which are very sore. When you crash, it's just like you black out for a couple of seconds and you wake up and you're all sweaty and you're a bit like, where am I? So that was, then I just decided, no, it's like, I didn't want it at home because I felt it would be too much of an intrusion, very difficult, 24 hours, everything at home. Hospital was good, 7 to 11, so I got home normally about 12. Friends would come and pick me up, friends would pop in to see me, and or the children would come pick me up, or there was a hospital driver who was really good, who's now passed away. Him or his wife would, they would take you in and bring you back home. So November was then, it's a bit tiring. It's quite tiring, the dialysis. Even you're young or you're old, it does take a strain on you. It does, it's difficult. And you still push along, but you're a lot slower than what you normally are. And come November, when I went for my tissue typing and genetic matching and everything, we were told that the match was as good as can be. So the operation, rather than having it in April 2017, was going to take place in December 2016, just before Christmas. I was very lucky. Genuinely speaking, I was very lucky. I have friends whom I meet at dialysis and during dialysis, friends out with. They've had transplants. Some have been rejected. They're back on the list. There are some friends who are waiting for transplants. on dialysis, it's really hard. You know, it's just really, really difficult. It is really limiting going on holiday, going out, just considering everything. You know, it takes its toll on everyone. Automatically, you know, I was blessed that my children were older, so they were more understanding. They understood the whole situation better, and they could speak to the doctors themselves. They could ask questions themselves, which was good. You know, you don't have to mollycoddle them or explain to them or say to them, okay, mummy's not well, mummy's going to be away for X amount of hours. And it was good. I felt bad as well. You know, there was a lot of pressure on them, that you're away from the home for like 5 hours, you're coming back, and it's like you've missed a block out of the day, and you've missed like the children. Like my daughter would FaceTime me sometimes for cooking in the beginning when I wasn't well at all. Okay, I'm doing this and I'm doing this. Is the colour okay? Is it mushy enough? It felt nice, but then it was good. Media and everything is connecting us, keeping us there, but it was difficult at the same time. But you can't show that to them, because you know, it's like it's hard on them as well. So I think they're strong and you're strong, so you're plodding along like in harmony. Diet restrictions were a tough one. I love cheese and onion crisps. I always get into trouble for having them. I still do. And so I didn't have any potato crisps during dialysis due to potassium content, because you were to avoid anything containing potassium, and those like tomatoes, potatoes. So I had my corn chips like Monster Munches and stuff. So anyway, went in for the transplant, touch wood, everything was fine. Really hard, obviously, because husband and I were both going to be in hospital. Children were going to be on their own. You have your friends, you have your family, but still they're on their own, and it was very hard. And I'm a very emotional person anyway. You show me a sad ad and I'll start crying. So you can imagine what I would have been like then. And but then touch wood, everything went well. My husband was well. He never wavered. I tried to convince him, well, let my cousin do it. You're okay. No, I've done it. I've said it. I've signed the form, and that's it. You know, it's all going to go ahead. So transplant went ahead, and my friend, I remember, called me and she said to me, what do you want? And I said, can I have a package of cheese and onion crisps, please? And she did. She brought me in a package of cheese and onion crisps and some rolls. So you can imagine me sitting there in the window having my cheese and onion crisp and my roll. And I was genuinely one of the really, really lucky ones to have the opportunity, not to be on the list, not having to wait X amount of years. I was very, very lucky that basically my time on dialysis was just like a little stopover, with the clock ticking until I went to where I was to be. So I was really, really glad, and I really say to everyone, if you can, please, please, please consider this and help us, help everyone, help all the Asian community. Thank you.
Oh, thank you so much, Azra. And I'm sure if we were in a conference setting, you would have had a big round of applause. It's lovely to hear the personal story. It's always so touching, and really, really resonates with people as to why we're doing what we're doing. And I appreciate that this is a different way for you to get your message out, a little bit daunting perhaps, but thank you so much again. As I say, we will have an opportunity hopefully to ask Azra and others questions at the end, and if you have just joined or recently joined, please do fill out the questionnaire. Otherwise, we are now going to move on to the next speaker. So it gives me great pleasure to introduce you to Dr. Radha Sundaram, who is a consultant in intensive care and anaesthetics at the Royal Alexandra Hospital in Paisley. Having qualified in India, she did her postgraduate medical, anaesthetic and intensive care training in Liverpool, Oxford and Glasgow. She's the regional advisor for training in intensive care medicine for the West of Scotland and is also a clinical lead for organ donation in Scotland to promote awareness amongst BAME communities. And over the last 5 years, she's worked with NHS Blood and Transplant, Scottish Government and ourselves to improve education and awareness in minority ethnic communities. And her interests in the area of organ donation include donation after circulatory death, and she's also produced a tool to prompt consideration of organ donation at the end of life in ICUs. Thank you, Radha.
Hi, Nirja. Thank you very much for this invitation to speak. Before I start, I would just like to thank Asra for such a powerful and such a moving account of her experience. I think what shone through for me is that you're such a positive person that despite all your personal hardship, it's this sort of your positivity that makes what we all do, you know, from sort of Linda, the Scottish Government, Fern, Nirja, Bushra, Dr. Ahmed, myself. That's what makes it so worthwhile. Seeing people like you come back and tell us how your lives have been transformed. Thank you for sharing that. I'm just waiting for my slides. So my name is Radha Sundram. Thank you so much, Danidra, for that introduction. I work as an intensive care consultant at the Royal Alexandra Hospital in Paisley. And I have been working with a number of agencies to improve awareness about organ donation for the last sort of 5 years. I think those are my slides, I can see them.
Those are those?
Yeah, perfect.
Lovely.
So that's great, thank you. So most of what I was going to speak has actually been covered in the previous talk. So I'm just going to tell you my experience as an ICU doctor. So most of the time I have the privilege of looking after people who are critically unwell and actually saving their lives. But unfortunately, in a small proportion of cases, we can't actually get the outcome that we all want. And care needs to be changed. The focus of care needs to be changed from a sort of curative care to actually comfort and dignity. And it has been a sort of tremendous privilege to help families and the medical and nursing team navigate that at end of life. The imperative for our communities is out in the media. I mean, I was watching Dr. Nighat Arif. She was on the news today as well, and she's been a sort of tireless campaigner for organ donation. And this is what she said. Her little boy, Kasim, who's just so cute, needed a liver transplant, and she has tirelessly sort of campaigned for organ donation. Amjad Ali, an ambassador for NHSBT and works with kidney research as well, has again worked really hard for us to be able to improve our awareness about organ donation in our communities, but also empower us to make the right decision to save people in our communities. But the truth, as Dr. Ahmed said, is that we need everybody because the pool is quite small. Less than 1% of people can actually be in a position to donate. You have to be in an intensive care unit on life support to be able to donate. And then there is also the issue of sort of family refusal, the issue of being in good health, to be able to have organs that can actually save other people's lives. So the pool is so small that it makes it important that we all discuss this and sign up to the register. We know that the number of people who donate from our communities is quite small. But how does one donate? So if one wishes to donate, we do so now by signing up to the NHS Organ Donor Register. But more important than that is to actually let your friends and family know that that's your decision. Because when you are in a critical condition and on life support, you are in no position to remind your family about that. And your relatives are devastated. They have been hanging in there, fervently hoping and wishing that you're going to survive. But they've had the news that that's not going to happen. And in order for them to make that make that decision, in order for them to actually authorize or give assent to donation, they need to know your wishes. So more importantly, we do need to discuss our wishes so that our families feel empowered to actually follow our wishes. The new law, Fern has eloquently sort of explained it to us. I'm not going to sort of labor any point, but Wales has already got an opt-out system, and currently you can do one of three things. You can opt in, just like you did before. You can register, you can opt out, or you can do nothing. But if you do nothing, you're actually saying that you have no objection to becoming an organ donor, and your family will be approached. The families will still be able to object to donation, so it is quite important that we let them know in health. Death is such an abstract concept, so in your early 20s, in your 40s, even in your 60s, it's not something that you discuss at your dinner table or talk about. But actually, if you did tell your family that you wished for donation, when you are in that position, then you empower them to make that decision. And we often see that when we approach families, patients who have actually discussed it with their families, they're the ones who bring it up, actually, even before we broach the subject with them. Again, some really, really sobering statistics. We are more likely to need an organ transplant in our BAME communities and less likely to be organ donors. And there is an urgent need for us to all opt in, or at least consider it seriously, because by doing so, we do improve the lives of many, many people. And why do families refuse? Now, it's understandable that families feel as if they've been hit by a train or a truck. So as I say, patients come to the intensive care unit because they're critically unwell. The medical and nursing team work very hard to save them. And then the conversation changes because we recognize that it's futile for us to carry on treating. And this decision of futility is never made by one doctor. This decision about futility is made by a consensus decision and is often made by the entire multidisciplinary team. And even if there is a shred of doubt, we will continue life-saving treatment. We then approach the families. The families are devastated by the news. They don't know what their loved ones' wishes were. They may never have spoken about it. They don't want to make the wrong decision. And actually, they're so paralyzed by grief and fear that they're not in a position to make that decision. They might have their own personal views about organ donation. They may have some misconceptions about the process of donation. They may feel that their religious beliefs prevent it. At the time that all our holy scriptures were written, the Bible, the Quran, the Bhagavad Gita, organ donation wasn't in the realm of thought really. So to look for explicit consent in our holy scriptures for organ donation is quite, I guess it's almost unrealistic. However, all our scriptures and all religions do focus on helping others. The lack of information, again, as the medical profession, perhaps we need to make our processes transparent and clear. And by events like this, we actually are able to explain things to people and disabuse them of their misconceptions. So as I said, when a patient comes to intensive care, we treat them with respect and dignity to try and save their lives. But for a very tiny proportion of patients, the focus of care needs to change because we have established futility. And at that time, we don't withdraw care. We continue to care, but the focus is comfort and dignity. Many hospitals, certainly all the hospitals in Scotland, use a tool which helps us navigate this. So we do have to have the comfort tool, it's an acronym, and C is the consensus decision regarding futility, and all have to agree. There's often a misconception amongst our communities that we might be withdrawing treatment or changing focus just to promote donation, and that never happens. If there's a shred of doubt, we continue with life-saving treatment. And I must say, in my experience as a consultant for about 14 years, often the families tell us that I think you should stop even before we tell them. We consider organ donation. We now approach every family and ask them whether their loved one has expressed the wish. We have access to the organ donor register. We have a specialist nurse in organ donation who's embedded in our unit, so they are there to help us have this conversation. Once we make sure that all the medical documentation is complete, we inquire if the family have other family that would want to visit. We inquire about the religious and spiritual needs, and this is for all families, regardless of whether they wish to donate or not. And we do help them to sort of with keepsakes and making memories. It's often very difficult to discuss death, and as Dr. Ahmed said, that you would think with our experience and the amount of data that we collect about death, we would actually be able to define death and have a sort of unarguable definition of death. But as you can see with all the fatwas that are there, the various discussions in various religious forums, death is a very, very interesting concept. But the biological definition of death is the irreversible loss of essential characteristics which are necessary to the existence of a living human person. In order for donation to proceed, death has to happen. Now, death can happen in two ways. We can either donate after brainstem death, where we define that the brainstem, which is a vital part of the brain, which controls our circulation and respiration, is not functioning anymore. And we call it now donation death by neurological criteria. Or we can donate after circulatory death, where the heart stops. So previously, donation after brainstem death was called heart beating donation, and donation after circulatory death was called non-heart beating donation. I have to assure you that doctors will always do their best to save the lives of patients, but unfortunately, sometimes we can't. We will approach the families and speak to them about donation. If the family, and this is pre-law change and with the law change, if the families do not wish to proceed, then regardless of the wishes of the patient, medical teams will defer to the wishes of the family, because the families are the survivors. We do not want to leave them with a burden of grief and confusion. So if they say no, we don't proceed. The other reason for not proceeding if the families refuse is because we need the engagement of the families for a lot of information about the medical history of the patient. The specialist nurse spends a lot of time with the families to seek medical information. They also go through GP records, records from all medical files to make sure that the patient had no medical contraindications to be able to donate. Because after all this, after putting the family through all this, if we cannot actually save the lives of the people by ensuring the viability and or quality of transplanted organs, it would really defeat the purpose. We also are very honest with the families about the length of time that this takes. Donation is a lengthy process, and NHSBT are always trying to reduce the time. There are some religions where there is a need to do the sort of rituals and the rites within 24 hours, and the teams will always keep that in mind. And if the family wish to change their mind at any point, they're allowed to do so. Brainstem death is when there is a sort of traumatic brain injury or a bleed in the brain, and there's evidence that the brainstem, which is a vital part of the brain that controls respiration and circulation, is not functioning. We are very lucky and fortunate in the UK that we have a robust ethical and legal framework that helps us to define brainstem death, and also all our regulatory agencies give us the sanction to be able to approach the families about donation. And if donation is consistent with the patient's wishes, values, and beliefs, we are given the sanction to proceed with donation. As Dr. Ahmed alluded to, actually determining that someone is brainstem death is done by 2 doctors, one a consultant and one doctor who's qualified for at least 5 years. It's a legal document, and the number of tests that are done to make sure that there is no chance that the brainstem is active. Sometimes we have to do more tests. In this case, the patient actually is in the intensive care unit and connected to the ventilator, and this is heart beating donation. The family stay with the patient until it's time to go to theatre. The specialist nurse in organ donation contacts the various centres, the transplant centres, and at this time, the call that all the patients who are on the kidney transplant waiting list and the liver transplant waiting list, they get the call that they've been waiting for, and they then check into the hospitals. Now, this could be in Scotland, it could be out with Scotland, depending on the compatibility of blood groups and other testing. The family are offered spiritual and religious help. Once the team that come to do the retrieval arrive in the hospital, the family can decide whether they want to stay or they want to go. We often find families leave at the point that the patient is taken to theatre. The patient is looked after by an anaesthetic and surgical team, just as they would if they were having an operation in health. All religious considerations are adhered to. There are lots of misconceptions about mutilation. The teams look after the patients just the same way. The ICU nurse who's been looking after the patient does not leave the side of the patient. Nothing changes as far as the patient and the family are concerned. The family are given an opportunity to say goodbye once the operation is done. Once the retrieval process is done, the patient is brought back to the unit, and at the family stay, they're given an opportunity to say goodbye. What we find happens is that once the patient goes to theatre, the family members leave. Our specialist nurses in organ donation and the ICU nurses help to build memories. They have a memory box, fingerprints, a lock of hair, whichever would give the family comfort. Donation after circulatory death, these are patients where the heart has to stop for donation to proceed. And again, treatment is deemed futile. We approach the family, and in Scotland, when they give us consent, we call it authorization. The retrieval team has to be in attendance, so we only change the focus of care when the retrieval team are in attendance. And this can only happen if asystole or the heart stops within 3 hours, because the organs, again, as I said, if we go through all this distress for the family, we want the organs to be in a condition that they actually save the lives of the people that they're transplanted into. Again, the operation commences with respect, care, and attention. Families often leave the hospital at this point. The specialist nurse in organ donation does get in touch with the family immediately after the operation to tell them the outcome. They then give them a lot of follow-up calls, and all our specialist nurses have a very, very enduring relationship with these donor families. The donor families are commemorated for what they've done. There is usually a ceremony in Holyrood, and they are given the St. John's Cross. These are heroes because this is the most distressing time in their lives, but they've actually found the courage to say yes, to be able to save other lives. And I guess, why do we do what we do? We do what we do because it gives a little boy like Kasim the hope to live a full life and enrich everybody's life. And we also do what we do because we know that by saying yes to donation, families actually feel a sense of meaning and purpose. This was a letter from a family who said yes to donation. We have a number of donor families who come forward and speak, and they tell us that the only thing that keeps them going is the legacy that their relative has left. The fact that their son or daughter or mother or brother lives on in somebody else, in 9 other people, has given sight by donating corneas, heart valves that would actually save the lives of young babies. That is the reason why they say yes. Thank you.
Thank you very much, Radha. As always, a very insightful and detailed overview of the fantastic work you and your teams do. Okay, we are running slightly behind, but I do want to give full time to our next esteemed speaker. So I'd like to welcome Abdul Aziz Ahmed, who was born and educated in Nottingham, went on to study at various universities in the UK, USA and South Africa. He qualified as a primary school teacher, but has held a number of posts in education, including head teacher, and most recently, continuing improvement officer for North Lanarkshire Council, and has been seconded to duties as HMIE and SQA. His Islamic studies have taken him to various parts of the Middle East and Africa, including Tunisia, Jeddah, Egypt, and Kenya. He's written, translated and edited a number of books on Islam, education and social inclusion. Thank you very much, Sheikh. Can we see you?
You able to see and hear?
I can. Everybody okay?
Okay, so can everybody see the slides? Okay, so
Let's go ahead.
yeah, all right. So just to follow up quickly from a few points that have already been made, there's 3 points in particular. I think it's quite important for me to just reiterate. Fern had mentioned that this is a very personal decision, and that's really very important that we focus on that. That this is not somebody else deciding about what's going to happen to your loved ones. It has to be taken into we have to take account of these decisions, of the issues around this, because it is a very personal matter. Dr. Said had pointed out that at this crucial point we often refer to our religious scholars, but in many cases those religious scholars have not always got the full depth to all of the issues that are at stake here. And Dr. Ed had also mentioned that the importance of sharing that your opinion or with your close family, and that's really why we're here, is to look at these issues, start to reflect, and to share this discussion before we're put in that position where we may be where we may have to make those decisions. So what I'm going to try and do over the next few minutes is to talk about three things. One is to go over the principles that are at play from a Muslim perspective when we are making those decisions, to look at some of the legal opinions, and then to just point out that there are many unresolved issues still from the Muslim perspective, and that things will be changing, and that we need to work together to look at how things will develop in the future, so that we get a further clarity, and that hopefully there will be less and less contention around this, and it will be much easier for people to make those personal decisions. So let's look at what the two principles are. So we have two principles within Islam which seem on the surface to be going against each other when we look at the question of organ donation, and because they seem to be diametrically opposite. For that reason, it becomes a real difficulty for people to make a decision about what does Islam say about the issue of organ donation. So the first one of these is that the body, the human body, is sacrosanct, whether it's alive or whether it's dead, and it should not be tampered with, it should not be harmed, and that it is something which is sacred. So this is the first point. And the second point is that preservation of life is one of the higher goals of Islamic law. So here we have two principles which play against each other, and therefore the discussions about whether it's permitted or not permitted will fall under how these two principles relate to each other. So let's look at the first one and how Islam looks at this principle. First of all, it says in the Quran, وَلَقَدْ كَرَمْنَا بَنِي آدَمَ, that we have indeed honored the children of Adam. And what that means is all children of Adam, the human body of just by definition, this is a human being, then that means that is a sacred entity. It's something which is connected to the divine. So this honor is whether the body is alive or whether the body is dead. And the Prophet Muhammad ﷺ had made this clear, that breaking the bone of a dead person is the same as breaking the bone of a living one. So this honor and dignity is attached to the dead body. So that's the first principle that lays down that impacts on our discussion about organ donation. However, on the other side of that, you have that the idea that the preservation of life is a principle within Islamic law. So what does that mean? You have, we all know that certain things are haram, or forbidden, and among those things are eating of donkey, the drinking of alcohol. However, both of these things change when the question of preservation of life is brought into the formula. And the example of this is where the Prophet Muhammad sallallahu alaihi wasallam was on a journey, and the only food that was permitted to be eaten was available for them was wild donkey. And in this particular occasion, the Prophet Muhammad sallallahu alaihi wasallam allowed them to eat what would, under normal circumstances, be haram, and therefore what is under normal circumstances haram would become halal, would become permitted. So therefore, and the reason why is that preservation of life overrides everything. And it says in the Quran, as the verses mentioned there, وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. Whoever saves the life of one person, it's as if he saved the life of all of humankind. So here, the preservation of life, of saving of life, is something which is fundamental to the Quran and is fundamental to all religions, as Dr. Red had mentioned. And she said that those principles are found in all of the religious scriptures. Within the Quran, we have a verse where Allah subhanahu wa ta'ala says, وَيُؤْثِرُونَ عَلَىٰ أَنفُسِهِمْ وَلَوْ كَانَ بِهِمْ خَصَاصَةٌ, that they prefer others over themselves, even if it causes them difficulty. So here we see that this love of humanity, the love of preservation of life, or the need to preserve life, has to be balanced against that principle which we discussed earlier, which is that the dead body can't be touched. Now, I'm just going to reflect for a minute on my own personal journey. I first witnessed a post-mortem when I was very young, and we're talking of 40 years ago. And when I saw the body after it had been after it had undergone this examination, and it was very distressing. And at that point, as a young man, I was against the idea of organ donation. However, as I grew, so to speak, and I experienced more and more having to wash bodies as part of the funeral procedures, you could see that the damage, or the way that the body was treated, as medicine has progressed, is completely different to the way it was 20, 30, 40 years ago. And at the same time, I was also working for a number of charities where we were working with people like the young lady that spoke earlier, who had received organs. And my journey was to weigh up these two principles, and it became very clear to me, and I'm not going to pretend, it's very clear to me that the second principle overrides the first. But as I say, that's a personal journey that I've been on, and everyone that looks at this issue has to make that personal decision, as Fern had mentioned earlier. So let's look at what the scholars have said. First of all, some have said it's haram, some have said it's forbidden, and among those they base it on a statement of the Prophet Muhammad sallallahu alaihi wasallam, who said, Allah's curses on a woman who wears false human hair. Now, why is this relevant? Because what it mentions, and why the scholars have used this to say it is forbidden, is because the implication of this is that the human body, the dead human body, has been used, or part of it has been used, to benefit a living body. And based on this statement of it being cursed, they have drawn on this source and come to the conclusion that it is forbidden. So this is the basis of why people have said it's forbidden. However, those that have said it's permitted go back to the example that I've just given about alcohol, for example. It becomes permitted when it is used for saving life, to the extent that if it's the only thing that will save life, it not only moves from being forbidden, it becomes compulsory to save the life using the alcohol. And therefore the scholars who say it is permitted say, based on the principle that al-dururat tubih al-mahzurat, that the necessities permit the prohibited. So these are the two. When Dr. Saeed had mentioned there are many fatwas, many scholarly opinions, they basically fall into these two camps. One based on the earlier suggestion, the hadith I just mentioned, and then the others based on this. So where do we stand? As I said, I've been on this personal journey, and I'm not the only one. All scholars have gone through this, and we can see that the way that in a few minutes we'll see how the first fatwa, so to speak, on this it dates back to the 1950s, and you'll see that many of those scholars over those years have moved and changed their position. Now, what was thought to assist this change in the law was to try and get a decisive fatwa, for that reason, one of our scholars here in the UK, a very noble and scholarly person called Sheikh Mufti Zubair Butt, he produced a fatwa which it was hoped by many people would clarify this question once and for all. However, it actually raised more issues than it solved. And one of the difficulties was that with this particular fatwa is that the headline of the fatwa is that organ donation is fine or is permitted. However, if you go into the detail of the fatwa, you'll see that he's very specific, and he says that it is unlawful to take. He says that he stated that brain stem death or even whole brain death alone are not sufficient to indicate departure of the soul, and as a result it suggests the impermissibility of organ donation following determination of brain death prior to irreversible cardiac arrest and circulatory standstill. Let me link that to some of the things that have already been said. Dr. Saeed had said that 60% of transplants come from people that have died and have been declared with brain death. Now, what he's saying, what this fatwa says, is that that many of those would not be permitted. Now, that's problematic because it gives an unclear message in my view. And what we need to do is to look at what are the issues that have been raised by that. And the key issue is, at what point do we say a body has died? At what point do you say a person has died? And that is not a simple matter. I like it's not something that has been it's not something that's unique to the Muslims. It's not unique to the British. It's for all human beings that are facing this question. And this particular article summed up the need for looking at the cultural aspects and the religious aspects of what is death. And it says the moment of death is among the most mysterious of all human transitions. Culturally defining death may be as complex as defining life itself, and may vary depending on whether one views it spiritually, medically, ethically, legally, or otherwise. Thus, the concept of brain death poses a great challenge to clinicians who may be required to bridge the interface of culture, religion, law, and medicine. And for this reason, it's not simply that a doctor can say that this is the answer. And likewise, it's not possible for a mufti or a sheikh to say this is the answer. The only way forward to come to a clear or conclusion of what we mean by this is for us to work together. And it's not something that is unique to the Muslim community. In fact, the writing of Pope Benedict is actually, in my view, some of the most forward thinking on the question. And he said, he summed up his argument was that these changes that I've just described in one aspect of medical practice, but it's just reflected across a whole series of medical advances. And he points out that society has not had sufficient time to accept the change to a paradigm in which death does not follow the pattern of heartbeat arrest. So in other words, he's saying that traditionally we understood death in a particular way, and that's something that Dr. Saeed had pointed out, that we thought of death in this way, but actually now we're not so sure. And this question of not being so sure is very important when it comes to that particular fatwa of Mufti Zubair Butt. So let's look at what That's what the Pope said very wisely about brain death. However, likewise, the Muslim scholars have also pointed out that at a conference in the 90s concluded that there is neither a precise definition of death nor a precise description of how to recognize the departure of the ruh from amwat, from the dead, in either the Quran or Sunnah. So here we don't have a simple answer that this is when death occurs. So what we do need to do as the Muslim community, in particular the Muslim scholars, have to look closely, more closely at what that means and how that applies to this very, very important decision about organ donation. Now, I'm just going to reflect for a few minutes. As I said, I'm making it clear what my position is, and I'll argue for that position using the Quran and Sunnah, the basic text of Islam. But first of all, let's look at what the dictionary definition of death is. And this is the dictionary definition of al-hayy, of something which is alive, has two qualities. One is idrak, is able to perceive, and fi'l, is able to do. So if somebody is considered to be alive, these are the two qualities within Arabic language that we use. And that's why in Arabic language we use life and death in almost as a, we say that somebody is more alive than others. And this is found in a very important hadith where the Prophet Muhammad sallallahu alaihi wasallam says, "مثل الذي يذكر الله والذي لا يذكر الله كمثل الحي والميت." The one who remembers God and the one who is not aware of God are like the living and the dead. And what this means is that the quality of life is related to these two aspects. So here within the linguistic understanding of what is death, there is a connection to the brain, to being rational, to be able to think, and therefore those who talk about death of the brain is actually completely within the linguistic and Quranic understanding of the word death. In particular, when we talk about sleep, we call the sleep, and the Prophet Muhammad sallallahu alaihi wasallam called sleep al-maut as-saghir, the small death. And the reason why is because the rational faculties have left the body, or the body has parted from the rational faculties. So here, the idea of the brain dying, it is well established within the early understanding of the Quran, within the linguistic understanding of the Quran and Sunnah. And so we shouldn't really have a difficulty in developing that to get a clearer and more precise description within the limitations that have already been discussed about the difficulties of defining the exact point of death. So let's look at how that journey has taken place across historically across the Muslim world. As I said, there were fatwas which were given in the 50s to permit certain types of donation. The first one to discuss brainstem death very clearly was in 1964. So we're talking of more than nearly 60 years ago, and that has now progressed. And you can see as we move along up until 2010, which is Qatar. Almost all of those countries have moved to the point where organ donation is accepted, and brainstem death or brain death is the definition of when death occurs. So there's only two important exceptions to that. One is in Kuwait, the Religious Ruling Committee have still not clarified that, and there's still some debate about that. And the last one is Egypt, and I'm going to come to that because Egypt has this particular relevant reason why that is, and that relates in part to some of the misconceptions about death and the intentions behind this, and may explain some of the things that Dr. Saeed has said about the fake news that's been spread about organ donation and the changes to the law. So there are many unresolved issues. The first point is there's no consensus among Muslim scholars as at the moment, and therefore the Muslim community needs to work further to try and bring around that consensus, because as Dr. Saeed has said, many of us, when it comes to those difficult decisions, Dr. Radha has described how how that discussion might take place in intensive care. But the reality of what really happens in those points for a Muslim whose family is dying, often they will wait for the imam to come along and say yes or no. Unfortunately, that's not, I don't think, is good enough, and I think the Muslim community, we need to start working on that. Some of these decisions are kind of pointed out here, but I'm going to go over them very quickly because time is short, and this is maybe not relevant as relevant to this particular discussion. So even when we've got the definition, there still remains opposition. And I'll give you an example. That when one of those examples was Morocco, and when it was introduced in Morocco, the law was introduced in Morocco, 24% of doctors in a particular survey in a hospital weren't able to define what is meant by death under the current law as it was introduced, and 35% could define the law but didn't accept it. So here, even though in principle there's a lot of cultural work that needs to be done to overcome the stigma, so to speak, within our community. And when it comes to the skepticism, the reason why Egypt is one of the dissenting voices is because when the law was introduced, it was introduced, and the first organs that were donated were actually of people who had been executed, and so there was a whole ethical question about why did the government introduce this law? What are people doing with organs? And for that reason, in Egypt, the law has not moved forward because of the skepticism within the community, and that's the kind of thinking that was behind the misinformation that has been put out. And I've had many people come to me and say, well, look, you can't support this law because it's against Islam. This is we need to work on this, and this is a very good step forward by an organization like Al-Mizan, and I'm very proud to be part of that. As Muslims, the community needs to work together to still look at some key discussions, and I hope that there'll be opportunities for the Muslim community to look at some of these things that I put up there about those medical questions, which can't be discussed completely in medical terms. They need to be looked at collectively, as we're doing today with Muslim scholars, Muslim doctors, and non-Muslim doctors who have a keen interest, and legal and people from the government. So that's the way forward, and I'm very glad that you've given me this opportunity to make that short presentation, and I hope it's stimulated to some discussion about Islam and organ donation, and I look forward to any questions later.
Thank you so much, Sheikh Abdulaziz. It certainly has given us lots of food for thought, and that was a very clear and very informative talk. Thank you. So we're about to move on to questions. Just before we do that, and I'll tell you how to do that, can I ask Saeed just to come back on very briefly, just to share with everybody the questionnaire to be completed after you've heard everything today. Saeed, you're going to share the questionnaire? Yeah, if you could quickly talk us through that. Thank you.
Yeah, well, thank you very much, everyone. So this is the questionnaire, and it's important that we do take part in the questionnaire, because we're collecting this data for a number of events we've done already. We've done 8 events already through British Islamic Medical Association, hopefully many more to raise the awareness. And so this will form part of a data set, which really lets us know that we're doing these webinars correctly, we're getting the right information, and really looking at the qualitative and quantitative information that comes to us, so we can look from a research point of view, what are the issues and where do the pinch points lie, and where we need to have increased awareness. So please do take part. This is the first time we're doing it electronically. Normally we do it on a piece of paper at the end of the physical meeting, but obviously due to COVID, we're moving on to the electronic field here. So I would be very grateful if you can do part A and part B. Part A now should have finished, and you should be doing part B. It's only like 2 pages long, and mainly asks about your views pre and post the discussion. So if you've done part A, that's great. Just do part B after the Q&A now. Thank you.
That's great. Thank you so much, Saeed, for quickly reminding us about that. We are slightly running behind schedule, but that's only due to the hugely informative and very passionate speakers that we've had. However, I would just like to ask for a bit of forgiveness in advance. In the interest of time, I would like to just prioritise questions for Sheikh Abdulaziz first, if we may, and then we'll make sure that other questions are covered in one way or the other. So if you'd like to ask a question, you can either type it into the chat bar on the right if you don't want to speak or be seen for whatever reason, or if you'd like to come on video, then just do put up your hand. It's the if you hover your mouse around, there's a bar at the bottom, it says reactions, so you can put your hand up. And Bushra and Shama, if you see anyone's hand up, can you let me know? Rifat? Yeah, a question for Sheikh?
Yeah, assalamu alaikum warahmatullah, Sheikh. Pray you're well, inshallah. My question to you is, you spoke about the dead brain and the statement from Imam al-Ghazali, but what I wanted to clarify was, so many scholars speak about also the dead heart. So how can we ascertain that when Imam al-Ghazali was speaking about the dead heart, sorry, the dead mind, he's not talking about it in a spiritual aspect? Jazakumullah khair.
Yeah, you're absolutely right. He is talking in a spiritual aspect, and that is what his primary intention is in this. However, what I wanted to do was to point out that linguistically, the understanding of the word life is to do with those two qualities, which is idrak, perception, and to do with action. And so linguistically, the word life, whether it's applied in a spiritual sense or whether it's applied in a legal sense, has these two qualities. And you're absolutely right. Ghazali is using it in that particular way, but I think it still stands that that's what the word actually means, and Allah knows best.
Saeed, did you have a question for Sheikh?
Yes, thank you, Nir, for letting me ask a question. The question is, I think this in the Islamic faith, and most of our leaders are happy with the DCD, so death after cardiovascular death. There is a provision in the law that when you opt in to be a donor, you can say only if I have a DCD death, which then gets around that little bit about DBD, because DBD is more common and it's probably preservation to the organs a little bit better because the heart's still working, everything's still working, so the organ is in good quality for us to take. DCD, we make sure that everything is stopped, i.e. the circulation stops, so the organ may not be as good quality. But in my field, we know that even then in DCD, these organs are still good quality enough to donate because we've been doing it, and new ways of taking these organs mean that they're almost as good as DBD. So there is a provision in the law which allows you to specify, I'm not happy with DBD, as Sheikh has pointed out, maybe I'm happy with DCD, and therefore that's the only death I would be happy to donate under those circumstances. And my family agrees, I agree, put it down, let everybody know.
Yeah, that's a very important point, and I think that's where the guidance that will be coming from the Scottish Government will probably be hopefully indicating that you don't have to opt in or out. It'll be that you can make that provision, as Dr. Saeed has mentioned. But I think what's most important is that we have this discussion amongst ourselves as a community, amongst ourselves as a family, so that people know exactly where you stand. And in previous discussions where I've had this with many people, people feel comfortable with coming to a conclusion that that is what we believe, that I will donate my organs, but only after circulatory death. And if they've made that clear to their family, then that is going to be within what's required from within the law in Scotland. And I think that is a very, very important point, that if you're not comfortable with one, that doesn't mean you have to opt out. And that's why we need to have this discussion. And thank you very much for making that point.
Thank you. Rifat, was that yourself again with another question there? Is that Rifat Fatima? about the standing. Someone's asked, what is the standing on receiving the organ donation from the Islamic scholars? Sheikh Abdulaziz.
I think most of the scholars have said it applies to both the receiving and giving. Receiving and donating have the same weight. So in effect, if you believe, this is where it's slightly problematic, that if you believe it's haram to donate, then you really should be questioning whether you want to receive. And that's why I personally have no difficulty at all, because I accept that the fatwas that have said that it is permitted, and therefore it's permitted to receive and permitted to donate. And in reality, they should be both seen as the same ruling. And Allah knows best.
Thank you. Asia, I can't see you, but if Almazan can unmute her. Oh,
Hi, can you hear
yeah.
me? Yeah, my question is, I'm on the organ waiting list at the moment for a kidney. And my question is, I was offered one at the beginning of beginning of June, but for some reason it wasn't accepted. So I'm back on the waiting list, and I just want to know if anybody knows how long I would need to wait further.
Do one of the medics want to take that one?
Okay, I'll take that one. So it is very difficult. There's no prediction model to tell you that how each particular patient, how long they wait. We know in a group, this is how long you wait. Each particular patient has their issues. So when that organ was going to be offered to you, your consultant would have been called that night, and he or she plus the surgeon would have made that decision. If you're fit enough to receive, or the organ is of good quality for you, particular, because that particular consultant knows your case very in detail. So these are the decisions we make all the time as consultants on behalf of our patients, because we want the best organ at the best time. So if you didn't receive it then, you'll be waiting, yes. I'll say how long is difficult to say, because the capacity and demand I talk about is changing. COVID changed it a lot, but it's also changing behind the scenes as well.
Thank you, Saeed, for taking that one. Are there any other questions, please, for Sheikh Abdulaziz? No, I'm not missing any, am I? Okay. Sorry, Saeed.
Just one comment.
Yeah.
Where I just said about DBD, DCD, where you can make that choice. That only came about due to, well, not pressure, but people asking for a change with NHSBT rules and UK law rules. So if you don't ask for it, change can occur. So we put that provision in, and I know about 20 to 25 deaths have been where that provision has been put in. So people are using that little clause. It's not well known, and therefore you should use it more often. But it was due to people pressure that that clause was put in. If you speak to NHSBT in UK, England, and also in Scottish Government, they will tell you that clause is there now.
Thank you. Anybody else? Does anybody else have questions for Sheikh Abdulaziz? Okay, I don't think I can see any. Bushra, can you see any other questions? Any hands up or emoticons up? No.
Yes, please.
Asia? Asia, did you want to ask another question for Sheikh? No.
Just I'm on dialysis and stuff, and obviously, as you can imagine, it's not working too well. So I may be looking at going back to hemodialysis, which is an option I don't really want to go through. So I'd rather just get a transplant ASAP. But it's not really a question; it's just a statement, really.
Mm. And that's why I mean, that's why, you know, we're doing projects like this with Scottish Government in Scotland and other places in England to really try and raise awareness about this issue and get people to really consider organ donation so that they can help people like yourself. So we're trying to do everything we can, and I wish you all the best. So we've got a few more minutes. If there's no other questions for Sheikh Abdulaziz, then can I just open the floor for other questions for the other speakers, whether that's Bushra, Azra, Radha, Saeed, Fern? Saeed, is that you? Or Rifat? Rifat, yeah, go ahead.
So I have one question to Bushra, who said that one donor can save 9 lives. So, and then I do have another question. I don't know if you want me to just, it's just what Fern was saying, and I just want to know, does the new form that we're able to now register online, does that contain the DCD option as well? So 2 questions, please.
Okay, we'll take Bushra's first, and then Fern, if you could answer the other one.
Hello, hi, assalamu alaikum. Okay, so one person can save up to 9 lives. That's we can donate liver. I'm going to just go through them. Nurja can correct me if I go wrong. So it's liver, lungs, kidney, eyes.
2 kidneys.
2 kidneys, sorry. 2 kidneys, liver, lungs, eyes, pancreas, lower bowel. It's going.
Pancreas, have you said pancreas?
Yes, pancreas.
Do we split
heart,
the lungs?
Heart.
Liver, yeah.
Liver, yeah. So the 2 kidneys make up, like, you can give 1 kidney to 1 person. So before it was eight people, but now it's 9 because 1 kidney can go to 1 person and the other one can go to another person.
Yeah. Did we miss any rather?
I think that I've covered everything. Eyes,
yeah,
eyes, lungs, liver, yeah, obviously, and there's tissue donation as well.
Yes, exactly, yeah. Okay, Fern, could you answer Rifat's other question?
Yeah, so the options about DCD and DBD, it's not an option to make that choice on the register, but it is written into the law in Scotland that when clinicians address the family and speak to the family about what your views were, part of that discussion is about whether in the particular circumstances you'd be willing to donate. So that would be about, for example, whether you'd be happy in the circumstances, whether it's DCD or DBD, to donate in those particular circumstances. So you might have wanted to opt in on the register and ticked opt in that said to your loved ones, I only want to donate in these circumstances. And as part of that conversation with the family, that question has to be asked. And so donation could only go ahead where it was compatible with what your views were. Does that answer your question?
Yes, and if I can just say, so say for instance, it wasn't very clear, so say it was a different family member and something wasn't very clear whether they wanted to donate or they didn't, then is the choice still the family's choice, or in that case, what would happen?
So the whole principle behind the new law is it's about the potential donor's views. So the person who's nearing death and could potentially become a donor. It's the discussion with the family is about finding out what their views were. It's not about what the family's views were or what the family's views are. It's about the potential donor's views. As has been touched on earlier in the evening, this is a really difficult time for families. So clinicians would never want to progress a donation where it's distressing the family because they're objecting to it. So in practice, it's unlikely to go ahead, but it is written into the law that it's about the potential donor's views and putting those views first.
Okay, thank you very much.
Thanks.
Rava, did you want to add something?
Yes, and to sort of Rifat's question. So our approach sometimes when we speak to families about donation, about the difference between DCD and DBD, and if they, because of their faith or their views, wish to only proceed if it's DCD, then the organ donation team, along with the medical and nursing team, will facilitate that. Because it's about respecting the dying person's wishes and not causing any grief or distress to the family. And we've had that. We've had a Hindu family in the west of Scotland a couple of years ago where they were keen on donation, but they weren't keen on donating after brainstem death. The patient was actually brainstem dead, and the tests have been carried out, but they felt uncomfortable with that. And so treatment was withdrawn and donation proceeded, and then the heart did stop. But they were very reluctant for us to say they were brainstem dead, and we will sort of honor the family's wishes. I must say the process is explained very, very clearly and in detail by the specialist nurse and organ donation, the specialist requesters that we have in Scotland, and ourselves. So the family do have the opportunity to ask various questions, and we would do what the family wished in practice. And as Fern says, the law is to actually empower the family to respect the dying person's wishes. It's not for the family to actually express their own views about donation. And when patients actually opt in, families find it very, very hard to go against the wishes of their dying relatives. So they'll say, oh, I find this uncomfortable, but my brother is on the register. How can I go against his wishes? And that's why it's important, even with the change in law, for us, if we are passionate about donation, to actually opt in.
Thank you, Radha. Was that okay, Rifat?
Yes.
Sorry, Dr.
Yes,
Singh, I'll come
thank
to you in just a moment. We have a question that I'd like Bushra to take. Somebody's asked, what is the standing on this by other religious communities, mainly from BAME? Bushra?
Okay, so it was Rifat Fatima. We work very closely with the Hindu, Sikh and Muslim communities within Glasgow, Edinburgh and surrounding areas. What we have seen over the past 7 years is there have been no major issues within the Sikh and Hindu faith. We have numerous people sign up within their faith. For the Hindu community, it's all about giving. That is the main concept, and again with the Sikh community as well. Our peer educators, we have many of them volunteers, many of them from the Hindu faith members. So there's been no major issue. Obviously within this Islamic faith and people that we speak to, because of the different schools of thoughts, there's always questions. But again, that's why we do these events. We have sheikhs coming to speak and to be able to answer questions. So I hope that answers your question.
Thanks, Bushra. And Radha, if you could answer this one, please. It's from Nabila. She's asking, is there an upper age limit for donating or truly dependent on health?
There isn't an upper age limit for donating corneas, and even for kidneys it seems to be edging upwards. I don't know if Dr. Ahmed would be able to clarify, but certainly for hearts it's a bit lower. But it does depend on the chronic health of the patient, and actually as sort of preservation techniques and retrieval techniques are improving, certainly for the heart, because they're able to use these regional perfusion techniques, the organs are in a better condition to be able to give a long life to the person who actually is fortunate enough to receive it.
Thank you. And although we're talking about organs, we do know of people who've donated tissue well into their 80s and early 90s. So it really does depend on health. And likewise, the other way around, that, you know, some people in their 40s and 30s may not have, you know, good functioning kidneys, hearts, lungs, so they may not be able to donate. So it really does depend on their health at the time. So Dr. Singh, Inderjit Singh, I'll bring you in here. Hello. You're on mute.
Yes. Oh, sorry. Am I on the mute?
That's all right. We can hear you now. Who's your question for?
One of the doctors, please.
Okay.
Radha, Dr. Ahmed Syed Ahmed. What really I wanted to know, when we say that the family's opinions really matters, if there is a conflict of opinion within the family, will you take whose is the priority? Is it spouse, children, parents, or you just don't do it?
Yes, that is a very difficult position to be in. And actually the next of kin is the person who makes the decision. However, if there's any sort of dissent, what we often, our specialist nurses and our specialist requesters are very good at managing it and ask them to go away and think about it. And often they come back with a decision to donate. I have been involved in a couple in the last a couple of decisions like this in the last year, and actually the families have gone away. It is the older members of the family who are not keen on donation, not because they don't think donation is a good thing or receiving an organ is a good thing. They just don't like the idea of the sanctity of the body in some way being changed. But the younger members of the family are quite pro-donation generally, and they're able to sort of convince their older members. And we've had that twice now, where they've come back and said, yes, we want to proceed with donation. It makes it easier if they're on the organ donor register. So if they've opted in, it makes it very easy.
If they don't come with a consensus, then you won't take it.
It will depend on the medical team that day, but most often we defer the side of not proceeding, which is such a shame, particularly if the patient would have wanted to donate.
But is there any list you have, the priority that spouse is the highest in the rank, or the children, or the parents?
Not in Scotland. But every patient who gets admitted to hospital has a listed next of kin, and they are the ones that will make all the decisions really.
So, say in my case, if I go to hospital, next of kin, my son's name will be there, but will my wife not have the priority?
It's the person who you nominate as your listed next of kin.
And if you are not in a position to.
We go back on your medical records with your previous admissions, but we do get family dissent, but we wouldn't want to leave the family in any way distressed by this whole conversation. But as I say, families often seem to resolve their own dissent just by the way we share the information with them. If you're opted in, often families then come together and agree. If you've not made your wishes known, it makes it very difficult.
Thank you.
Thank you very much, Radha. I'm so sorry, I'm going to have to finish there. We are just 2 minutes over, and I do thank you all for keeping your questions and your answers brief and concise. We have now finished. I'd like to extend a huge thank you to all of you for attending. We've had a good turnout, and a huge thank you especially to all our esteemed speakers for taking time out of their evening. And also a thank you to our host Al-Mizan for making sure all the technology has run smoothly. It's been a great success for the first time. And of course to our funders, Scottish Government. Now, if you do have any other questions, or we've somehow missed anybody, the number on the flyer, which was Bushra's number, you can message her on that number, and we will try and answer any other questions. But otherwise, we hope to have many more of these in the future. So please do look out for us. And I'll just make sure, Bushra, is there anything else you want to add at all? You're on mute.
Yep, sorry. So I've just there was a question, I think, for asking a question, a medical question. But what we'll do, so I was going to say, so what we could do is I've just put up my email address and my contact phone number. So if anybody wants to text me or email me, and then I can pass your messages on to the relevant speaker, and we'll get your questions answered, if that's okay. It's just I'm quite conscious of prayer time as well now, so that's why I would like to close, if that's okay.
Thank you once again, everybody. Goodbye.
Thank you.
Goodbye. Thank you.